Good evening, and welcome to NCODA's Student Educational Talks. Thank you for joining us for our first presentation of 2021. I would now like to turn it over to Nicole Mayham, a pharmacy student from Shenandoah University, for our opening remarks.
Hello, everyone. This is Nicole from Shenandoah University. NCODA's mission statement is our focus is to offer an international community for healthcare students with passion in oncology and pharmaceutical industry. We provide education, leadership, mentorship, and opportunities in research and community outreach. We promote unique and dynamic experiences for students to collaborate with all oncology stakeholders. I would like to welcome all of the established NCODA professional student organization chapters. South University, University of Rhode Island, Midwestern University, North Texas University, Washington State University, Texas Tech University, Purdue University, Nova Southeastern University, Massachusetts College of Pharmacy and Health Science University, University of Minnesota, University of Toledo, Albany College of Pharmacy and Health Sciences, University of Iowa, Lake Erie College of Osteopathic Medicine, Auburn University, University of Missouri, Kansas City, Binghamton University, University of New Mexico, Belmont University, Wingate School of Pharmacy, University of Florida College of Pharmacy, University of Utah College of Pharmacy, Howard University College of Pharmacy, Temple University, Shenandoah University, and Oregon State University. I would like to welcome all of the in-progress NCODA professional student organization chapters as well. Thank you for continuing to help us expand. Welcome all students. Welcome any and all students listening in. NCODA will be providing student educational talks to students regardless of membership. NCODA is growing by leaps and bounds. We are now over 2,970 members and over 530 practices strong. Working together, we become stronger. Stay up to date on all NCODA student events and resources by following the NCODA Professional Student Organization Facebook and Instagram page at facebook.com/NCODA Professional Student Organizations, or simply scan the QR code on the screen now. Also, don't forget to follow NCODA's LinkedIn page for all national updates.
Thank you, Nicole. I'd now like to turn it over to our first presenter of the night, Mi-Lin Oh, a pharmacy student from the University of North Texas.
Hello, my name is Mi-Lin Oh. I'm a P3 pharmacy student, and tonight I'll be presenting on relapsed Hodgkin's lymphoma treatment, specifically the autologous stem cell transplantation. Next slide, please. So the objectives that we'll cover in this presentation today, we're going to go over what the hematopoietic stem cell transplants are and their use in medicine. We're going to go over what Hodgkin's lymphoma is and their use in treatment for refractory Hodgkin's lymphoma. We're going to go through the transplant process that patients go through, and specifically we're going to go over a Beam regimen, which is going to be the most commonly used regimen. We're going to go over brentuximab and for its place in treatment. I'll go over some terms about the stem cell transplant process itself, some complications that can arise, and gonna go over what the future of stem cell transplant research looks like. Starting with hematopoietic stem cell transplants, what are they? It's the process of transplantation of multipotent hematopoietic stem cells. The stem cells come from multiple sources, can come from bone marrow, peripheral blood, or umbilical cord blood. And the types are autologous, meaning yourself, allogenic, someone else, or synergetic, use of a twin. So these are the contents that we'll go over today in the slides. Next. Let's first start with the medical uses of stem cell transplants. So the type of diseases that they're used to treat, for example, are like blood cancers such as leukemia, Hodgkin's, and non-Hodgkin's lymphoma, as well as multiple myeloma. It can also be used in aplastic anemia and some autoimmune diseases as well. Next slide. All right, let's go over some blood cancer facts. Approximately every 3 minutes, one person in the US is diagnosed with a type of blood cancer. Just to put that in perspective, an estimated combined total of 178,520 people in the US are expected to be diagnosed with leukemia, lymphoma, or myeloma in 2020, which just passed. And new cases of blood cancer will make up about 9.9% of all new cancer patients. So for Hodgkin's lymphoma, let's go over the pathology first. It's going to be identified with abnormal B cells that turn into binucleated Reed-Steinberg cells with abnormal T cell proliferation. So the Reed-Steinberg cells, they lack the immunoglobulin genes that normal B cells express. So it's also important to note that the Reed-Steinberg, Sternberg, and the T cells will have the CD30 plus markers on them, which will be important for later. And about 10 to 20% of the patients that have Hodgkin's lymphoma will have refractory Hodgkin's lymphoma some point in their treatment. So as far as diagnosing it, you have blood tests like complete the CBCs, PET scans or CT scans, biopsies for tumors, as well as physical assessment. Okay, let's go over staging. So there are 4 stages. Stage 1 being only a single lymph node area or a single extranodal site that's present. If you have 2 or more lymph node areas on the same side of the diagram, that will automatically put you at stage 2. As far as stage 3, that means there are lymph node areas on both sides of the diaphragm, with that at least being 2. And stage 4 encompasses the disseminated or multiple involvement of the extranodal organs. Let's go over storage of said cells. All right, for your stem cells that are removed, they will be undergoing cryopreservation at a rate of 0.3 to -4 degrees Celsius per minute. And then eventually they will be stored at -80 degrees Celsius and mechanical freezers. This is extremely cold, so you do need specialized freezers for such treatments. The preservatives that are used include what is listed, and these are important because these allow the cells to be stored for up to 15 years, just in case the patient needs them in the future. Now we'll go over conditioning regimens. So we might be asking, what are conditioning chemotherapy regimens for? So the regimens are used to completely suppress the bone marrow in the patient from producing new cells and enter what is called a nadir period. This suppression allows the newly transplanted cells to engraft and for the body to create new hematopoietic cells. So listed are the different kinds of regimens that are available to patients, and we'll specifically be going over the first one, which is called Beam, and it's substituent drugs. All right, so as far as Beam, as you can see over here, we have the carmustine, the BCNU, etoposide, Saitara Beam, and melphalan. So as far as this one goes, this is the most frequently used regimen for patients for the induction therapy because this regimen has been shown to have the least amount of organ toxicity relative to the others and their combinations. All right, let's go drug by drug. We're going to start with the carmustine. Its dosing is 300 milligrams per meter squared, and it's going to be done as an infusion over 2 hours on day -7. So -7 refers to like a week before your stem cell transplant actually occurs. The toxicity we're going to look out for this drug are going to be specifically pulmonary and nephron toxicity. And then the side effects are mostly the emesis due to this particular drug being diluted in ethanol. And so a lot of the side effects you're going to see is going to look a lot like alcohol, like poisoning. And to manage these side effects, you can administer antiemetics like 30 minutes before infusion. The classification of this drug is an alkylating agent. Next, the E in Beam is the etoposide. Its dosing is seen as 800 to 1200 milligrams per meter squared. It's going to be a once a day drip that's going to be on days -6 through -2. Its main toxicity we're looking for here is the myelosuppression, and its side effects that we're really looking out for are the hypotension and the Stevens-Johnson syndrome that can be seen. As far as managing the side effects, we're gonna do that antiemetics 30 minutes before infusion. And if SJS does occur, you don't stop this infusion because you do need it for the patient. However, you can slow the infusion rate to help with management and administer some Benadryl as needed. For classification, this medication is a topoisomerase 2 inhibitor. All right, next is Saitara Beam. Its dosing is seen as 1600 milligrams per meter squared. It is infused as a drip over 30 minutes twice a day. The main toxicity here is that myelosuppression. And as far as the side effects go, this one is like, it's not that long since it's only 30 minutes, so the patients can actually suck on ice chips during infusion times to decrease oral ulcerations by preventing or by inducing vasoconstriction in the mouth. The classification is an anti-metabolite. All right, and next we have the last drug in Beam, melphalan. So this one is also administered as a drip, and this is going to be just on day 1. And the main toxicity is myelosuppression. It is important to note that a major side effect is going to be the diarrhea with this drug and the ulcers. So the diarrhea and the pamphlet that it comes with is very severe for these patients. They can have up to 18 to 40 bowel movements in one day. The diarrhea might last a week, might last more than a week, and it can take more than 6 months for GI function to return to normal. Its classification is anti-metabolite. All right, so what is another adjunctive medication for relapsed Hodgkin's lymphoma? This one is going to be the brentuximab vedotin. So remember when we said about the CD30 positive markers on the cells? Well, this is where that comes into play. The MOA of this drug is that it's an anti-CD30 antibody. Its dosing is seen as 1.8 milligram per kilogram with a max dose of 180 milligrams every 3 weeks until there is no more active cancer. The side effects we're looking at here are the neutropenia, peripheral neuropathy, and SJS. As far as toxicity, we are worried about the hematologic and the pulmonary toxicity. As far as its place in therapy goes, this medication is used before the week of conditioning for the stem cell transplant to target those specific Hodgkin's lymphoma cells. And for most patients, this will be before beam therapy. All right, so when does the stem cell transplant happen? It happens within 24 hours of finishing the melphalan drip, the in beam, and then the stored stem cells are transplanted as a drip into the patient's bloodstream. So as far as adjunctive medications go, we're going to help manage the very low white blood cell counts with granulocyte colony stimulating factor injections. For how this looks on treatment, from day 5 after the transplant, you'll have the injection each day until your WBC is above 1 for at least 24 hours if Neupogen is used. So the two options you have are the Neupogen and the Neulasta. And both of them, you're going to look for the anaphylaxis that could happen with either one. So these are the variations of beam therapy that are available. So the first one is going to be Leam, where instead of the carmustine, they're going to use lomustine instead. And this might be a better option for patients, especially if there's concern of pulmonary toxicity already. If, for example, if you're a smoker, you're asthmatic, or you have COPD. The second option is Dexabeam, which is Beam plus dexamethasone. So this has been shown to be highly effective at achieving remission. However, there are no studies yet to compare how the outcomes are with Beam. As far as Mini Beam goes, it's the same medications as Beam, but at lower doses. And this is mostly going to be used in your elderly populations where they can't really tolerate as much of the toxicity, but they still would like to go through treatment. What is engraftment? So engraftment is when the cells are reinfused after the chemotherapy treatment, and the body can make new blood cells in the bone marrow. This usually occurs within 30 days after the transplant takes place. As with oncology, we've got a lot of complications with our therapies, and this is no different. This one has the increased risk of a second malignancy because of the drugs that we use, organ impairment due to the chemotherapy toxicity and side effects, reduced quality of life due to patients experiencing PTSD from treatment, lack of energy, altered mental ability, reduced libido, as well as infertility. Infection is something that we do look out for and help our patients with. And we also encourage them to do vision checks at least annually. So what's the prognosis look like for our patients? Well, in 2020, there was a 5-year progression-free survival rate of about 40 to 50%. The current 5-year survival rate, however, has increased a bit from previously to now being 50 to 60%. Looking to the future, research. Every year, new cancer medications are approved by the FDA, and the future of research really needs to compare the long-term efficacy and safety profiles of medication regimens. Ultimately, the goal of research would be to find a way to make the autologous stem cell transplantation process less toxic to patients and to help maintain their quality of life after the transplant. And these are my works cited. Thank you very much, everyone, for listening.
Thanks, Milan. I would now like to turn it over to our next presenter, Ginger Blackman, a pharmacist here with NCODA.
Thanks, Austin. Are you, next slide, please. Are you? So I am a new member to the NCODA team. I joined in June and I came from Cancer Specialists of North Florida. I was the pharmacy manager there for 8 years previous. So I'm really excited to be on this side of things. And I'm really excited to get to work with the students and talk to you guys tonight. We took University of Florida and a couple of other university APPE students, and I do miss, that's one thing I've missed since we've kind of come over, is working with you guys. So I will go ahead and let me just give this disclaimer. You all obviously realize essential oils aren't regulated by the FDA. So next slide, please. So we hopefully will have a session on this at the NCODA, one of the NCODA national meetings this year, but integrative medicine is really growing in oncology. There are several of the major centers that have their own programs, and even my smaller community center, we had about 30 providers between medical oncology and radiation oncology, are trying to get more into integrative medicine just because the patients are requesting it and they do see benefit in treatment. So as you can see, there are many types of integrative medicine, from acupuncture to yoga. I will point out on the bottom that About Herbs app. So that's from Memorial Sloan Kettering, and anyone can download that. Our physicians used it a lot, but you all may want to check that out if you never have. It's a really interesting tool to have. So next slide, please. So my why. I think I was placed perfectly after Milan's presentation, which that was very interesting. Thank you. So when I was in my 20s, right after pharmacy school, I was diagnosed with non-Hodgkin's lymphoma, and I actually had an auto transplant in 2008 because I relapsed. So I was part of, then after that, a group of young adult cancer survivors, patients that we have here. I'm in Jacksonville, Florida. And I went to an essential oil class and I loved it. That kind of set the spark. Really, obviously, I'm a pharmacist. I love medication. I believe in it, but I also believe in using some more natural things with myself and with my family. And then I had a CEO who was also a pharmacist, and he wholeheartedly embraced this and allowed me to go get a certification and us to start a program in our pharmacy. Next slide, please. So a little about the history of essential oils. The use of aromatic plants is originally part of herbal medicine. It dates back thousands of years. Several countries, you can see them all listed here. So from China, France, India, Switzerland, and the US have all used it. René Maurice Gattefossé is considered the father of aromatherapy. He coined the term and wrote the first book. Next slide, please. So, and in his book, he was a chemist and he was also a lavender farmer, and he had a vat of lavender oil, and he noticed that when he applied it, he had gangrene, that it stopped the gangrene. So that is basically where his study started and where it came from, and it just moved on from there. Next slide, please. And then there are others, an awarded Army physician who wrote a book, the first book by a physician. There was Marguerite Mari, so she was a nurse. She basically classified essential oils into different disease states and types and how to treat things, and established some of the first aromatherapy clinics in Europe. Next slide, please. So essential oils are synthesized and stored in different sites in plants. They're found in the leaves, seeds, petals, roots, bark, and they can occur in more than one site in a plant. So for example, cinnamon, you can have cinnamon bark oil and cinnamon root, and the different oils from the different sites actually have different chemical properties. So there are many theories on why essential oils exist. A lot of them have to do with protection and also possibly a pollination. You can see all of those on the slide. But next slide, please. So to get an essential oil, they're either distilled or cold pressed. The citrus oils are cold pressed normally. And they have concretes, absolutes, resinoids, and CO2 extracts. So during steam distillation, the plant constituents are vaporized and then they're condensed on cooling, and it produces a mixture of an oil phase and an aqueous phase. The oil product is the essential oil, and then it also produces a hydrosol. Next slide, please. And this is just an example of what a steam distillation, what the process looks like. Next slide, please. So there are different types of aromatherapy. Aesthetic aromatherapy is using the essential oil for the pleasure of its aroma. That's basically someone may get a diffuser and they may consider it a more natural candle, basically, and just diffuse it because you like the scent. There's clinical aromatherapy, and that targets a specific clinical symptom. So example, in a patient undergoing chemotherapy may have nausea, and then you're treating that symptom and measuring the outcome. And there's holistic aromatherapy for the mind, body, and spirit. Next slide, please. So essential oils, thank you. There are 4 routes of essential oil absorption. So topical, that can be using massage, compress, bath, the little roller balls, if you've ever seen them, we would make bottles for our employees and our patients. Inhaled, so directly or indirectly, diffusers, fans, humidifiers, aroma sticks. This is the fastest method. An aroma stick is what we used a lot, and our patients also would use. It looks like a tube of lipstick, but it's like a long cotton piece. You can take it out and you put 10 to 20 drops of the essential oil or combination on it. You stick it back in, and basically you can take the cap off, and it's a way for the person to be able to inhale the oil without having to diffuse it for everyone around. And that, again, when I say inhale, it's just sniffing, basically. Internal via the skin, mouthwashes, gargles, oral gelatin capsules are diluted in honey. So we never recommended internal ingestion to patients. There are several people on the outside who do, but we just do not, because we don't know the long-term effects. So we have all these people who are ingesting oils. I don't know if in 15 years it's going to come back with some kind of liver toxicity that we didn't know existed. Next slide, please. So it's all about chemistry. It's a pharmacist's dream. So essential oil constituents contain a basic frame of a carbon and hydrogen to which a functional group is added. The functional group is a group of atoms in the shape. The shape determines the characteristic chemical properties of the molecules. And the 6 classes that are important in aromatherapy are alcohols, aldehydes, esters, ethers, ketones, and phenols. Next slide, please. So the classes of chemicals can determine therapeutic effects, and isolated chemicals have certain effects, but the synergy of the parts of the complete oil yield the biological response. So similar to how they say vitamins, when you extract them, they can have a certain effect on the body, but it's really like the whole food that's going to give the body the most benefit. So an oil is very similar. And then there are Gcms reports, which is, I'll show you a diagram on the next slide, and these are important. So if you ever do decide or at a place that carries essential oils, or even you use them personally, I always recommend that you buy from a supplier who will give you these reports. Because it is showing that they're doing their due diligence and testing their batches of oils. So next slide. So this is what a report looks like. It basically just breaks down the the largest amount of chemicals in the oil, and you can see on the right, it gives the percentages. And then those chemicals, again, are going to determine how the oil behaves in the body. Next slide, please. So for therapeutic purposes, the quality and wholeness of the oil are of paramount importance. The variation in quality can be natural or due to human intervention. The natural variations are similar to wine. So just like wine, at the same winery may have different vintages. It just depends on when it's harvested, the year, when it's processed and bottled. The variations in oil are similar, and it's due to all of those things that nature controls. So sunshine, rain, frost, heat, cold, and the soil composition. Next slide, please. So a word of caution to you as a provider, and then also to patients, adulteration can occur. So cheaper oils or synthetics may be added. It's another reason why you really want your supplier to be able to produce those reports. Imitations, expensive oils can be imitated by using blends of cheaper oils to simulate the aroma. And then contaminants, so herbicides, pesticides, these are coming from plants, so they can end up as contaminants in the oil, and we always want to choose organic oils when possible. Next slide, please. So accurate identification is also important. It's imperative that the oil is properly identified. Just taking it back to biology, the scientific botanical name should be used. So that binomial naming system, the genus and species. And then oils also can have a chemotype name, and that's the same genus and species, but they differ in internal chemical composition slightly. A lot of times those depend on the area of the world where the plants are grown. Next slide, please. So storage and shelf life, air oxidation is a problem, so you want to store full with as little air as possible. Temperature, the heat speeds up the oxidation, so cooler is better, cool and a dark area. You want to, they should come in a dark colored glass bottle. One brand that we would use in the pharmacy, NHR, came in these really cool clear apothecary bottles, but they did come in an aluminum tin for each bottle. So we would recommend the patients always store the bottle of oil inside that tin to protect it from light. And then they can have a shelf life of many years if they're unadulterated. And even when they're blended, they can last up to 2 years, and refrigeration can help preserve the oils. Next slide, please. So blends, there's an enhancement of effect when 2 or more are mixed together. And so the synergistic effects can really make a blend powerful. Next slide, please. This is one example of an anti-anxiety blend we would recommend to patients, or even we had a wellness program in our facility, and we would have classes for our employees. We would provide the supplies, and they would come and make like an immune blend and anti-anxiety blend. But that's just an example of one thing you could do. We'd give them a roller bottle, and they would, a carrier oil, could even be olive oil. We usually like jojoba oil or coconut oil, and they would make their own blend. And there is an ONS study that shows decreases in anxiety and a significant change in sleep quality measures in patients undergoing chemo who use lavender oil aromatherapy. Next slide, please. And then in that blend, these are just what the different oils, some of the properties that they exhibit. For lavender, as most people can probably guess, it is the most used oil of all of aromatherapy. Next slide, please. So this is kind of what our aromatherapy program and practice look like. So our pharmacy, we purchased from 2 companies. One was NHR. They were out of the UK, love their oils, but it got a little difficult in shipping and getting them to us. There would be delays. So we went with a company called Plant Therapy that had a good wholesaler arrangement with us. They produced all of the reports that we needed. And we also really needed to have those on file too, just because we were a pharmacy. We would buy them at wholesale cost, and then we would have them for sale in our clinics and in our pharmacy. We educated the staff, so a lot of times we do presentations for the nurses and other staff through presentations and workshops. Our marketing person did create posters, pamphlets with basic information. NAHA is one of the aromatherapy professional organizations, so we took a lot of information from them. We would have a pharmacist available for consults in person or by phone. The phone was because some of our, like I'm in Jacksonville, our St. Augustine office is almost an hour away, and those physicians happen to really like aromatherapy. So they would usually put theirs in, and we would do those just over the phone. So the physician would make a request in EMR. Our EMR team did design and build an aromatherapy consult template. So we would be able to fill that out when we were talking to and counseling the patient, and then it would go as part of their patient record like any other document. So we, at the time I left, did not bill yet. The physicians just used it as kind of a value added service to offer to patients. but I have visited other clinics that have programs. One has Aromatherapy, and they have some other like nutritional programs, and some of their pharmacists are using, they call it incident to billing, and they're able to bill for their services. So hopefully that will be something that becomes even more, I guess, bigger and easier to do in the future. And then we also used it as a benefit for our clinic staff. They were able to purchase at cost. We ended up having a lot of nurses and even some of our physicians who got really into the essential oils. And that was just kind of a benefit that we could offer without, it didn't cost us anything. They were able to purchase at cost, and that ends up being significantly less than if you try to buy a good quality oil on the outside. Next slide, please. So here are some basic references, and then next slide. And that is all I have. So thank you very much. And thanks, Austin.
Yes, thank you, Ginger. I would now like to turn it over for our special presentation for our Genentech Minute. And I would like to welcome Kim Talek, a therapeutic area manager with Genentech.
Thank you, Austin. I'm excited to be here with you all tonight. And Ginger, that was the non-Hodgkin presentation, both very interesting. I enjoyed both of them. Thank you. So as Austin said, my name is Kim Talek, and I'm actually an oncology advanced practice nurse by training. I'm now working with Genentech in breast therapeutics. And tonight we're going to be talking about emerging perspectives in breast cancer. And I also would like to just take a minute to just tell you how much I respect the pharmacy profession. Coming straight out of nursing school, I had an oncology pharmacist that I work with by the name of Mark Bishop, who taught me so much. And so I'm excited to be here with you guys tonight. Next slide. Couple of disclosures that I have to go over with you. This program is presented on behalf of Genentech, and the information presented is going to be within FDA guidelines. This program is intended to provide general information about breast cancer and not the treatment of any individual patient. This program will be monitored by Genentech for adherence to program requirements. I am an employee of Genentech, and all these materials are property of Genentech. Oh, next slide. This slide presentation was developed in collaboration with Dr. Rita Nanda and Dr. Ritu Rao, both out of Chicago, both breast specialists. Next slide. So these are the objectives. We're going to be talking about emerging disease drivers and pathways in breast cancer, as well as biomarkers and clinical implications. And then we're also going to talk about some of the challenges and future directions in the management of breast cancer. Next slide. So we're going to start on just some background of breast cancer. Next slide. So, you know, there are many risk factors for developing breast cancer. However, the two biggest risk factors are ones that can't be modified. It's being female and then having another birthday. As people age, their incidence and risk for developing breast cancer does go up. However, the most common highest incidence of breast cancer in women are those white women 40 years old and higher. Although I will say that the incidence rates are converging among white women and African American women, particularly in the 50 to 59 year age group. These other risk factors, particularly genetics and individual characteristics there on the top right, are also powerful in somebody's risk for developing breast cancer, specifically family history of breast cancer at an early age, as well as germline mutations such as BRCA1 and 2 mutations. There are these other modifiable risk factors that are in the bottom left-hand corner that do have some bearing on development of breast cancer, but certainly not to the degree of the ones that we just discussed. Next slide. So breast cancer is divided largely into two histologic groups. There is the in situ carcinoma and then the invasive or infiltrating carcinoma. And invasive and infiltrating can be used interchangeably. And then in situ carcinoma is in two large subdivisions, which is ductal and lobular in situ carcinoma. And then you see invasive infiltrating carcinoma there has several subgroups as well. Ductal carcinoma, invasive ductal carcinoma is by far the most common, accounting for nearly 80% of all breast cancers diagnosed. Next slide, please. So another categorization of breast cancer that is extremely important is the molecular classification of breast cancer. And the advent of high throughput platforms for gene expression analysis has led to our ability to distinguish different molecular signatures for different breast cancers. And you see some of those listed here. You have, and the reason why this is important is they are prognostic. They can predict a patient's overall prognosis, and it's also can be predictive. These different types of breast cancer, these molecular signatures also can predict a patient's response to different therapies. So for instance, you have luminal A and luminal B, which you see in the different shades of blue. Luminal, those are both hormonally driven cancers. Luminal A is HER2, estrogen receptor, progesterone receptor positive, as well as luminal B. And luminal A is HER2 negative, luminal B is HER2 positive. And so the treatments for these are somewhat the same. They both are likely to respond to endocrine therapy, but the luminal B will also have the addition of probably a HER2 directed therapy that they may respond to, whereas luminal A would not have that because it's not a HER2, doesn't have, that isn't a growth driver for that cancer. And they both may likely have chemotherapy added to their regimen depending on the stage of the cancer. And then you also have this basal cancer that is there in the red, and basal is, it is not hormonally driven. So it's estrogen receptor, progesterone receptor negative, as well as HER2 negative. We also call this triple negative breast cancer. So it's unlikely to respond to endocrine or HER2 directed therapy, and oftentimes they get chemotherapy or in some instances immunotherapy. And then you have this ERBB2 positive type of cancer, which is also a HER2 positive cancer, and so they would be receiving HER2 directed therapy. Next slide, please. So this is the Tmn staging system. I'm not going to spend a lot of time going over this, but I do want you to know that there is and you certainly may already know this, but Tmn staging system speaks to the anatomical characteristics of a breast cancer. The size of the tumor, the nodal status, how many lymph nodes are involved, as well as the presence of metastatic disease. It does not take into account those molecular components that we just spoke of. And however, all cancers should be staged with, breast cancer should be staged with a Tmn staging system. And for instance, the tumor varies in number there, as you can see, depending on the size of the tumor. And then lymph nodes, the number of lymph nodes, and metastasis is just present or not. And when you look at this, and then you think about the guidelines that are out there, particularly like the NCCN guidelines, which many providers as well as insurance companies look at as to what the patient is eligible for. So staging of cancer is stage 1 through 4. And for breast cancer, there's a stage 1A, B, and C. And what the staging of breast cancer takes into account that this TNM staging does not is TNM is involved in the staging of a breast cancer, but with breast cancer, which is very different than other cancers, they also take into account that molecular signature of that individual cancer and decide which stage it is. And so that didn't actually happen until the publishing of the most recent staging guidelines, and that was back in, I believe, in 2017. And so if you had looked at these tumors just based on the TNM classification, it would be very different than when they added in those molecular, looked at those molecular targets. And actually, when they changed the staging, 35% of patients actually ended up in a different staging group, which changed their prognosis as well as what treatments they were eligible for. New slide, please. And this just goes over, you know, those TNM anatomic staging as well as the changing. And it does say on there the AJCC staging manual in case you all were interested in that. Next slide. So now let's talk about the 3 main subgroups of breast cancer. We're going to touch on those hormonally driven tumors, and then we're going to talk about the HER2 driven tumors, and then we will talk about that triple negative. Next slide, please. So the estrogen receptor, progesterone receptor positive breast cancers, when we are talking about hormonally driven tumors or those patients who are eligible for endocrine therapy, this is what we're speaking of. We're talking about estrogen receptor, progesterone receptor positive, or ER/PR positive breast cancers. Next slide, please. So why this is important is estrogen can be a growth driver for breast cancers. And actually 75% are ER positive, 55% are PR positive. Some may be positive in both, and they may be positive in one and not the other. And that's for invasive breast cancers. And so what happens when we're talking about ER/PR positive tumors, and this is specifically for estrogen receptors, the estrogen binds with the estrogen receptor inside the cell itself. And what happens is estrogen, when that binding happens, it can promote cell proliferation. Next slide, please. And so it can be a predictive biomarker in breast cancer. So ER and PR expression can help predict patients who may benefit from those endocrine therapies available. And this is such a strongly predictive biomarker that NCCN recommends that ER status should be determined on all DCIS as well as ER/PR for all invasive breast cancers. So ER/PR is detected using IHC, so immunohistochemistry on the actual breast cancer sample in pathology. And, you know, another thing to keep in mind about ER/PR positivity, it's not a positive or a negative. There is a degree of positivity that is scored from pathology. And so, for instance, you see here ER/PR positivity is determined if greater than 1% or greater of the cells stain positive for these hormones by IHC. But then low positive is between 1 and 10%. So sometimes you'll even hear discussion about strongly estrogen receptor positive, so versus those who are not. So just a little distinction there. There is a degree of gray there. And another thing to remember about this is that ER/PR positivity or negativity can change with reoccurrence. So let's say the patient has a reoccurrence of a breast cancer she had 2 years ago. It should be rebiopsies to evaluate whether or not it is, you know, the hormonal status is sustained, because it can change. New slide, please. New slide, please. Oh, Austin, I think that those slides didn't come out. New slide, please. Okay, now let's talk about the HER2 positive breast cancer. HER2 positive, next slide, please. So HER2 is commonly overexpressed in a subset of breast cancer. And HER2 is a protein on the outside of the cell. And it does occur in normal cells as well as cancer cells. And HER2 is actually an oncogene. So oncogenes control proliferation. And so HER2 oncogene is amplified or overexpressed. You hear people say overexpressed sometimes in 15 to 20% of invasive breast cancers. So as you can see on the cartoon on the right, the top one, normal HER2 expression is about 20,000 receptors per cell, versus if it's HER2 overexpression, it can be up to 2 million receptors per cell. New slide. And so the HER2 pathway promotes growth and proliferation in breast cancer. And so when you think about, let me just back up just for a second. So HER2 is human epidermal, HER2 is a family of proteins, and it's HER2 1, 2, 3, and 4. And like I said, there are receptors on the outside of the cell. And in order for those to be activated, HER1, 3, and 4 need to have a ligand before they can bind with other members of the HER2 receptor family. HER2, however, doesn't need to have a ligand to stimulate it to bind with other members of the HER2 family. It can bind with any of them at any time. So as you can imagine, if you have more of those HER2 receptors on the outside of the cell and they're readily available to dimerize with other members of the HER2 family, then that can be a problem, especially when its job is to stimulate cell proliferation. And so what can happen, as you can see on this slide, when you have the dimerization of those HER2 receptors, it creates a downstream signaling down to the nucleus of the cell that leads to several different things: proliferation, angiogenesis, evading apoptosis, and other benefits to cell survival. And not only is this a problem with the overexpression, but HER2 is a particularly strong mitogenic signaling pathway. And so that is particularly problematic when you're talking about this as a mechanism of a growth driver for breast cancer. New slide, please. And so HER2 is overamplified, like I said, 15 to 20% of breast cancers. It can, depending on the lab, most often IHC is used in order to determine HER2 overexpression. It can also, you can use ISH, either FISH or KISH, which are other complementary method to determining positivity for HER2. And we could get into this is a whole discussion in itself about testing for HER2, but for the purpose of tonight, I think we'll just leave it at that. Next slide, please. Next slide. Next slide. Okay, so now let's move on to triple negative breast cancer. Triple negative breast cancer is actually a very diverse group of breast cancers. Next slide, please. And as you can see here, there are many different molecular signatures for a triple negative breast cancer, because triple negative breast cancer, unlike the other types of molecular biology associated with a breast cancer, this one is not an inclusion criteria, it's exclusion. So triple negative breast cancer just means that it's not any of the others, right? It is not driven by hormones, by estrogen or progesterone, and it's also not driven by HER2 overexpression. And so triple negative breast cancer is actually a spectrum of different breast cancers, just meaning that it doesn't have those biomarkers. And so it's probably unlikely that there is going to be a targeted therapy specifically for triple negative breast cancer that really is widely responsive because of the fact that it is such a heterogeneous group of cancers itself. New slide. And unfortunately, triple negative breast cancer is characterized by shorter overall survival. It's a very aggressive type of cancer. The majority of deaths for triple negative breast cancer occur within the first 5 years after diagnosis. However, there is a little bit of a bright spot for triple negative breast cancer, because if a patient makes it to 8 years, it's very unlikely that they will ever have a reoccurrence after that point, unlike the estrogen and progesterone driven tumors, who can sometimes have very late recurrences, like greater than 10 years, they can have their cancer come back, which is, very sad for those patients. But like I said, that, is one, I guess, good thing about triple negative breast cancer. Next slide, please. So one other interesting thing, I said that it's unlikely that there's going to be a silver bullet for triple negative breast cancer just because it is so heterogeneous, but a couple of pathways, signaling pathways that are currently under investigation, and those are these internal downstream signaling pathways. That has been identified that there's abnormalities in a greater portion of triple negative breast cancers for the P13K pathway, which is a pro-survival pathway that allows the cell to survive for an abnormally long period of time. And then also in the MAPK pathway, which is a proliferative pathway. And so if there was some way to, intervene in that intracellular pathway that is a growth driver possibly for these triple negative tumors, that would be a possibility for therapeutic intervention in the future. Next slide, please. Next slide, please. Oh, we're going to skip a bunch of slides, Austin. I'm sorry. Next slide. Next slide. There we go. Okay, so I would be remiss if I didn't bring it, talking about breast cancer, if I didn't bring up these germline mutations that put patients at increased risk of developing breast cancer in their lifetime. So like I said, these are germline mutations. These are not acquired mutations. These are mutations that they got from their mom or their dad when they were born. And so, you see here that a combination of BRCA1 and BRCA2 gene mutations are responsible for approximately 80% of the families with hereditary breast cancer. So those are obviously the most common. So even though these hereditary and a lot of times people will say genetic mutations, they are genetic mutations, but they're hereditary genetic mutations because all mutations are genetic alterations, right? So this is a hereditary mutation. And these mutations that we know of account for about 10% of actual breast cancer cases. So even though we talk about it a lot, the incidence of this occurring within the general population is not extraordinarily high. However, it is very important to know and to be able to identify patients who may be at risk for having one of these genetic abnormalities or these hereditary mutations, because it can change their treatment options and also the trajectory of their disease. One other thing about these germline mutations, BRCA1, BRCA2, and PALB2, they also have a disproportionate amount increased likelihood of having a triple negative breast cancer versus a hormonally driven cancer. So something a little different about them. Next slide. Next slide. Next slide. Sorry, Austin. Next slide. Next slide. for the purpose of time, I'm going to have to skip this portion. Next slide. Next slide. Next slide. Next slide. Next slide. Okay, next slide, please. So we've talked a lot about biomarkers, and so biomarkers are a characteristic that's able to be objectively measured and evaluated, and you see as an indicator of biological processes, pathogenic processes, pharmacologic responses. And they really are placed in two main categories. Then there's also the pharmacogenomic biomarker. And so prognostic biomarkers provides information about the patient's overall cancer outcome regardless of therapy. And for instance, that HER2, their prognosis is not as good as somebody who is HER2 negative. And then you have predictive, and that provides information on the effect of a therapeutic intervention for a particular patient. For instance, ER/PR positive predicts the response to endocrine therapy. And then you have this pharmacogenomic biomarker. And this is really something that is very interesting, especially as an advanced practice nurse. I was an advanced practice nurse in clinics for 19 years before I came to Genentech. And it would be so wonderful to be able to predict toxicities for patients. And so this provides data on inter-individual differences. So it doesn't look at the biology of the cancer. It looks at the genome of the person and differences, and understanding whether or not they would be more likely to have toxicities and changes in some of the pharmacokinetics and things with different therapies. So next slide, please. So this is where I started in cancer care 25 years ago, this all-comer approach, where if you had a stage 3 breast cancer, everybody got the same thing unless there was a very distinct reason why you couldn't tolerate something. That was a differentiator. Versus now we've got this biomarker-driven approach, which I think you all are probably acutely aware of. And so you've got this biomarker-selected subset that we know is going to benefit patients. And then we still have those patients that we don't have that strategy just yet. Next slide. And so here are the NCCN and the ASCO CAP guidelines for biomarker testing for breast cancer. And as you can see, there are quite a few similarities. ASCO CAP guidelines have some additional recommendations for breast cancer testing. Next slide, please. So prognostic markers, next slide. Next slide. So we had already talked about this, but this is a graph depicting the overall survival for HER2 and triple negative breast cancers. And as you can see, if they are, that they do not have as good of a prognosis as those who do not have HER2 positive disease, or those who do not have triple negative disease. Next slide. And so this is very interesting to me because this slide actually demonstrates the importance of understanding the molecular biology of the tumor. And so this is a retrospective analysis reviewed for the data of 965 patients, and they were all node-negative invasive breast cancer with small tumors. So they were stage 1 tumors, less than 1 centimeter. And they were diagnosed at MD Anderson between 1990 and 2002. And so certainly the treatment was different at that time than it is today, but not so much in this particular set of patients. And so what we see here is that despite the fact that these all had small tumors, so the anatomic characteristics of these tumors were the same. They were small tumors, they didn't have any nodes, and they didn't have metastatic disease. But you look at the recurrence-free survival difference between these the molecular signature of these patients. So those with HER2 positive disease, 77% reoccurrence-free survival versus those with hormonal lead-driven tumors, 95.2%. So just speaks volume to needing to know the molecular drivers of a certain tumor. Next slide, please. Next slide, please. And so I'm going to go ahead and close this out today. And I just want to leave you with a couple of just lasting thoughts, which is, first of all, breast cancer is a very, very heterogeneous disease. So if you hear that somebody has breast cancer and they want to ask you questions about it, you know about this much information that is really necessary to have an impactful conversation with somebody about it. And, you know, the advances are changing, you know, on a monthly basis in breast cancer. And despite the fact that we have so many great options for patients now, which is so nice, especially depending on the molecular biology of this specific tumor, you know, every time something new comes out, it uncovers 10 more questions that we need to answer. And so this is an ever-evolving field, and it's all, though, for the good of those patients who end up having breast cancer. So I want to just thank you for your time tonight.